Kia ora. I'd first like to start by thanking Jill Bond, Helen Ralston, Rowan Heringa and Gabrielle, because I know how difficult it is to put together a forum like this, so thank you. My name is Janet Peters. I've been around health and mental health for a long time, and I'm here to give you a very personal view of people-powered services. This is the first time I've given a presentation in maybe 10 or 15 years. I'm more of a writer, and I'm not really a front person. However, I feel so strongly about what I'm talking about today that I'm here to hopefully challenge you and bring you along as part of the team. This presentation is in honour of my late parents and patients everywhere. I think this is a very powerful saying, and I think it's particularly powerful in health because sometimes people forget that there's always a feeling left after an interaction. My presentation today is really three parts. There's an A and a B, which is my mental health experience. There's a B, which is my physical health experience, and then in the middle, linking the two, is me on my soapbox, which is about adverse childhood experiences, which is a model developed in the States, which I'd like to briefly describe. We're all here today to work towards better health outcomes. In this audience, 1 in 5 people will have a mental health problem. So I'm in good company. The difference between you and me might be that I've had more therapy than you've had hot dinners. Okay, looking back, this is my family in the 1960s. My mother, father, brother, and I. What looks like a typical family at the time. Both my parents had mental health problems. My mother was often admitted to Tukanui Psychiatric Hospital, otherwise known in those days as the loony bin. My father was anxious, obsessive, and grumpy. And in the 60s, people didn't talk about mental illness at all. People had breakdowns. So the two words, the language of the time was breakdowns and loony bin. As a child, I felt very anxious about my parents, nearly as anxious as I am standing here today. But visiting the loony bin for my brother and I was really scary, and we didn't understand our parents' distress, what was going on. We worried it was our fault. Across all health, it's lack of connection that really hurts in times of stress, and at any other time for that matter. Good health services are all about effective communication, whether it's digitally or person to person. So in that situation in the 60s, what hurts? What hurts is that complex family issues are ignored, children's needs are ignored, no information is given, there's no language to talk about things. There are power inequities between the family and clinicians, stigma, discrimination from the community, connections are broken, and although we were a Pākehā family, culture at that time was ignored. okay, what works? Unfortunately, we don't always practice what we preach. I've got a list of things about what works, the top being information, choice, control, and feeling safe. People with mental health problems need what we all need: a meaningful job, a home, and friends. And in mental health, workforce development is critical, as staff are our only resource. So we need staff with the right knowledge, skills, values and attitudes to effectively support consumers in whānau. What works in a wider sense? We have GPs now taking a whole person approach. We've got online e-therapies, for example, John Kirwan's The Journal and the Lowdown and Sparks for younger people in mental health. We have got changes in attitude and behaviour, although we've got a long way to go. We obviously need to attend to culture, and we've got models such as Te Whare Tapawhā from Masonry. People are complex, and the older we get, the more complex health and mental health issues are evident, as I personally have found out. But I do believe, I was looking the other day at the Code of Rights, that's been with us for some time, and I do think that really is still an excellent list of rights to aim for. If we all complied with this, we'd have great services. You probably are aware of the health passport. I do think, again, for people who find communicating difficult, I think that's a really good tool. So in mental health, one thing that helped services change quickly, as Mary would have talked about yesterday, was that people with lived experience spoke out loudly over many years saying change was needed and this is what we require. Change in health is really hard and really slow. The last DHB I worked for was Waitemata, and I couldn't believe how difficult it was to make a change that everyone thought was a great idea. However, I believe that appointing consumer advisors, people with lived experience, single-handedly made the most difference to mental health services. And that meant people with lived experience advised clinical staff, reviewed policies, problem solved, were part of interview panels, examined students as part of a team. They can ask patients what worked and what didn't by interviews, focus groups and surveys. I was talking to someone the other day at a DHB and they said, oh, we've got that covered. We've appointed a, I think it was like patient advisor. And I said, that's not what I'm talking about. I'm talking about people with lived experience of that particular area. So I think we need to look a bit wider than appointing one person in a DHB to help a patient focus. I belong to Southern Cross, thank goodness, and they've got a really good way of asking me questions. If I ring up at the end of the telephone conversation, they say to me, 2 questions. Did we resolve your problem today? Yes or no? Would you recommend Southern Cross to your family and friends? Those 2 questions actually convey a lot of information. So what I'm saying is I think there can be really simple ways of asking patients their thoughts. And obviously in mental health we've been developing leadership and research. However, what's also really helped is that we've got some really good national policies and activities. These are just a few that I've outlined. We've got Like Minds Like Mine, which looks at the whole issue about discrimination, and I was lucky enough to be the first national manager of that program. We've got the National Depression Initiative with John Kirwan as a great ambassador. and I've worked on that for its lifetime, which has been about 10 years. We've got the Prime Minister's Youth Mental Health Project, and I have to say, I think this should be widely promoted because it's just such a great lot of work for young people. More recently, we've got the Ministry's Children of Parents with Mental Illness, and from my background, that is a really fantastic bit of work. We've also got Equally Well, which looks at physical health and mental health. So, to end this section, I'm going to say that I think it's critical for our future that the Ministry has, one, cutting-edge expertise in health areas and clinical expertise, but two, also disruptive, effective, forward-thinking leaders to drive and refresh policies from outside health. Now, this is when I'm going to get on my soapbox. Janet, on her box, raving incessantly to anyone that will listen. What I'm going to talk about is adverse childhood experiences, otherwise known as ACEs. It's my belief that it's never too late to have a happy family. So whatever has happened in childhood, we can work together to gain a child or an adult, a happier family, through trauma-informed services and through friends, wider family, groups and communities. Adverse childhood experiences are actually 10 questions. These 10 questions came out of a survey of 17,000 people in the US, and it was done by Felitti and Ander. They initially started looking at childhood abuse and neglect in an obesity clinic. And then they found, following people, that people with high ACE scores as a child had many health concerns in later life. These are the 10 questions, each one seen as an adverse childhood experience. But of course, we have other adverse experiences, for example, loss of culture, war, and earthquakes. Basically, the researchers found the higher the ACE score as a child, the more likely the adult is to have a higher number of health, mental health and addiction concerns, engage in risky behaviours, disability and premature death. I'm now going to read you a paragraph that's got really big words in it, and I hope I do it properly. So, the science shows the epidemiology of ACEs, otherwise known as the ACE study. We know the neurobiology of toxic stress from brain science. We know the long-term biomedical consequences of toxic stress, that ACEs are the #1 cause of health problems in the US. We know the epigenetic consequences of toxic stress, historical and intergenerational trauma. But the good news is, we know that resilience research leads to trauma-informed and resilience-building practices. Over 4 out of 10 is considered high, and as a child I had over 4 out of 10, probably leading to my extreme interest in this area. So the aim of services around this is working towards resilience and well-being for people. But the key issue is it's not what's wrong with you, it's what's happened to you. And I believe not only in health but cross-government, if we actually took this seriously, we could have a healthier population. Evidence suggests that ACEs can be mitigated through being sensitive to a person's experience and by working together to at least not re-traumatise a person. There's a formal framework to this called trauma-informed care. In Philadelphia, in the States, the whole state has taken on this issue. So the City Council and across government are all working together to try and prevent and mitigate ACEs. So key points of this section: consider trauma-informed service delivery within health and cross-government. People with lived experience are changing mental health services for the better. Nothing about us without us. And so I challenge physical health services to do the same. So, all health. What can I, the patient, do to help myself, and what can services do to help me? This is Janet in the 70s. Not a pretty sight. And I'm now 61, and I've had, shall we say, a colourful life. So we know that past choices and the ageing process and genetics and ACEs lead to present health. In the last few years, I've had knee replacements, lung surgery, melanoma, and now, as you can see by the way I've been hobbling around, a hip replacement. Any orthopaedic surgeons in the room? See you, morning tea. So, I've been around, one could say, and I'm going to show you examples of what worked in terms of healthcare and what didn't. In 2013, I had knee surgery. This is me coming out post-operatively. This is my first operation ever, so I knew nothing about surgery. In the past, one of my ACEs was a violent assault which left me scared of being tied down. So I went into that operation with that post-traumatic stress disorder memory, my usual Janet anxiety, and the help of a clinical psychologist. Before the operation, I did my research on Dr. Google, and I was given a brochure by the hospital that bore no resemblance to the process at all. Nothing I read or heard prepared me for the post-op situation, which was air puffers on feet. Whoever invented those should be put down. Various drains, a pain pump, sides up on my bed, lines coming out of me. I couldn't turn, sleep or move. And that don't even get me started on the rehab. Weeks of doing excruciating exercises while in severe pain. So I now have a fear of hospitals to add to the rest. Sometimes, though, it's the system. About 5 years ago, I took my 80-year-old father to his hospital orthopaedic outpatient appointment. Dad was very frail, had a walking stick. My mother also was very frail, was on a walker. The room was full of about 15 people who were obviously disabled. People who were amputees, older people, people on crutches and in wheelchairs. The clock said 1 o'clock. After an hour, I asked the receptionist, why does everyone come at 1? She said, that's the way we've always done it. That's not good enough, I don't think. So what hurts? From the patient's point of view, they can actually hurt themselves sometimes by being uninformed. My colleagues, Keith Petrie and John Weinman, found that some people didn't even know where different organs were in their body. They were clueless. Some people had very unusual and inaccurate perceptions of illness, and some people have a fix me approach. Recently, I was at Tauranga Hospital talking to a young doctor in ED, and he was telling me that some people say, don't tell me, I don't want to know the gory details. So some people really don't want to be informed. What hurts from a clinician perspective is lack of clarity, not understanding patients' anxiety, not asking about the whole person, the family, the context, not listening, and giving out poor clinician-written information, and not even thinking about people's cultural backgrounds. I know with my parents they had many admissions to ED, and the people they really loved their most were the volunteers who gave them a cup of tea because they had time to speak with them. It's interesting to note that the two definitions of the word patient are tolerant, long-suffering, resigned, or able to accept delays or suffering without becoming annoyed or anxious. Hello? I think we should turn that round to say patient's definition, informed, assertive, part of the team. Okay, what works? People being asked what they're worried about with regard to a procedure or an operation, and the clinician taking steps to help. People taking more responsibility for their health and being seen as part of the health workforce. Strengthening health literacy. In mental health we have a one-day workshop called Mental Health 101 for all frontline staff of government agencies. For example, WINS have trained 3,500 staff. So perhaps we could have Health 101, which is like the health equivalent, real basic information. What works is nothing about us without us. So always patient-reviewed information. And the Code of Rights goes without saying. As a registered psychologist, I recently reviewed all the Mental Health Foundation handouts on clinical issues. So I updated the information, updated the research and links to key agencies. As a former surgical patient, I could do the same for orthopaedic and surgical areas. If not me, then someone else. But good news. Last year, I had lung surgery. This time, it was going to be different. I talked to the clinical staff about what I was worried about. I hand-wrote a plan on one page in advance. That was put in my clinical notes. Admittedly, when I looked at my clinical notes, it was filed at the back, but the charge nurse was willing to bring it round to the front. I got support from friends and family before, during and after surgery. The process was really good. And I'd like to thank these people publicly. Diana North, who's a GP and a friend, Dr. Sarah Weeks, a psychiatrist. I went to a psychiatrist. I'm a psychologist. Psychologists don't go to psychiatrists. Sarah Weeks is fantastic. Jeff Garrett, respiratory physician, fantastic. Peter Allison, cardiothoracic surgeon, couldn't be better. Nursing staff at the Mercy, Ascot, wonderful. My fabulous GP, Liz Davies, and my friends and family. Thank you to all those people. Okay, in summary, eek. Find creative ways to ask patients about their experience, accurate, up-to-date, patient-reviewed information. Obviously, patient-reviewed and clinician-reviewed together is good. Strengthen education, health literacy. I saw somewhere recently, data is king. That was on a document. I thought the patient is king, or the patient's data is king. Change the language a wee bit. And please remember ACEs. At the very least, be aware of the possibility.